I'm Dr. Jacqueline Hanson, an O&G consultant at Palmerston North Hospital. I was trained in obstetrics and gynecology in the U.S. at the University of Kentucky Medical Center. I would like to present the risk and benefits of a trial of labor after cesarean section or vaginal birth after cesarean. Following this will be a question and answer session. We hope this presentation will answer your questions concerning cesarean section, trial of labor, and vaginal birth after a cesarean section. For a woman with a prior cesarean section, there are three possible options. 1, a successful vaginal delivery. 2, a failed trial of labor and a repeat cesarean section. Or 3, a scheduled elective repeat cesarean section. In 1916, the statement, "Once a cesarean, always a cesarean," was made at a New York meeting of obstetricians, and for the next 60+ years, this has been our management. But our studies and experiences have consistently shown that 60 to 80% of women can safely deliver vaginally after a previous cesarean section, and that a vaginal delivery is associated with fewer complications than a cesarean section. These include a decreased risk of hemorrhage or bleeding and blood transfusions, a decreased risk of infection, a decreased risk of blood clots, a shorter hospital stay and a more rapid recovery, fewer breathing problems for the baby, and fewer admissions of the babies to the intensive care unit. A failed trial of labor is associated with the highest risk, including hemorrhage, blood transfusions, infections, hysterectomy, operative injury, and rare death of the mother or baby. The most significant complication or risk associated with a trial of labor is uterine rupture. Uterine rupture is the tearing open or the rupturing of the scar on the uterus. The actual rate of uterine rupture is between 0.5% and 1.5%, or essentially 1 per 100 patients. The most serious complications of uterine rupture are hysterectomy, fetal injury, or maternal injury. The most common sign of uterine rupture is the fall in the baby's heartbeat or fetal distress. The type of scar or incision on the uterus is associated with the uterine rupture rate. A low transverse uterine incision, the most common type, is associated with the lowest risk of 1 per 100. The classical or T incision is associated with the highest incidence of uterine rupture, occurring in 6 to 12 per 100 patients. The type of skin incision does not always indicate the type of uterine incision, so it is important to review your operative records to determine the incision type. There are contraindications for a trial of labor. These include a previous classical or T incision of the uterus, a previous uterine rupture, conditions that should not be allowed to labor, such as breach or malpresentation of the baby, placenta previa, or previous uterine surgery, or a woman who adamantly declines a trial of labor and requests a repeat cesarean section. There are predictors of a successful trial of labor. These include if your previous cesarean section was for non-reoccurring reasons, such as breach, fetal distress, placenta previa, or high blood pressure. If you have had a previous vaginal delivery. If your labor is not induced, but natural labor. If you have a normal progress in labor. If your pregnancy does not go beyond 41 weeks. If your baby weighs less than 4 kilos. If the timing between your pregnancies is greater than 18 months. If you have a healthy, active lifestyle with a normal pre-pregnancy weight and a normal weight gain during your pregnancy. And if you are younger than 40 years of age. Conversely, there are factors that decrease your chance of success. These include, again, no previous vaginal deliveries, failure to progress in labor as the main reason for your previous cesarean section, induction of labor for greater than 41 weeks gestation, obesity, inactivity, and advanced maternal age. A special circumstance to be considered is induction of labor. Induction of labor remains an option, although is less successful than spontaneous labor. The use of prostaglandins for ripening of your cervix is not recommended because of the significant increase in uterine rupture rate and complications. But rupture of your membranes and the use of syntocin to augment labor appears to be safe if monitored closely. Other special circumstances include 2 or more previous cesarean sections and/or a twin gestation. Limited studies are available, but there are still a 60 to 80% success rate without any significant increase in complications for the baby or mother. Recommendations for the management of labor include labor and delivery in a hospital where an emergency cesarean section can be performed if necessary. The monitoring of the baby's heartbeat, since the most reliable and earliest sign of uterine rupture is a fall in the fetal heart rate or fetal distress. Intravenous or cannula access to administer fluids, drugs, or blood if an emergency occurs. Vaginal examinations to determine the normal progress of labor, since prolonged labor is associated with an increased risk of failure and uterine rupture. Epidural anesthesia is a safe option for pain relief during labor. In summary, a vaginal delivery after a previous cesarean section is successful 60 to 80% of the time. Uterine rupture is a rare complication occurring less than 1% of the time. All patients who have had a previous cesarean section should be given information on trial of labor and vaginal delivery. They should have a thorough discussion of their options with their midwife, who will refer them for consultation with the physician.